Good afternoon. Today I want to discuss the topic this pharmacology of hemopoietic system. In this system, we can go antiplatelet drugs. What is antiplatelet drugs? What is the mechanism behind this? There is a non-nucleated disc-shaped bodies derived from megakaryocytes in the bone marrow and present in the blood at code of 1.5 to 1.4 lakh per microliter of blood. In here, there is CAMP, that is cycloadenosine monophosphate metabolized by PDE to 5-AMP, and hence any drug which inhibits this enzyme would increase the CAMP levels and inhibit platelet aggregation. For example, that is what means diphenhydramine. In normal undamaged vessel, the endothelium plays active part in prevention of thrombus formation. When the vessel is cut or endothelium is damaged, exposes the subendothelial collagen 1 to 4 types, leading to secretion of VWF, that is von Willebrand factor. Here it is activated. The platelets have high affinity for the subendothelial cells. They adhere and activation of platelet occurs, and they stick to one another, aggregate and release ADP, serotonin thromboxane. Serotonin, they promote further aggregation and platelet plug is formed. So simply you can understand whenever there is an injury happen, immediately the platelet plug formation will occur. How it is occur? Immediately first the endothelium make all the platelets all over the body, all over the blood vessels come and occupy here. So first occupy there, the platelet plug formation may happen. Afterwards, when the clotting may occur. Okay, this is a small mechanism. Okay. So here in veins, due to, you see here what will happen? Platelets, how it is adhere here. So platelets adhere to damaged vascular endothelium via linkage of glycoprotein, that is GP, 1A receptors with exposed collagen, and via linkage of GP 1B with von Willebrand factor, a circulatory factor that is similar to clotting factor 8. The adherence of platelet to the vascular endothelium leads to activation of platelets and release of various mediators of platelet aggregation, including TXA2, ADP, 5-HT. These mediators increase expression of GP2B, 3A, and that receptors that bind fibrinogen and cause platelet aggregation. This is a major mechanism. So this mechanism you can understand means we can easily write in this exam. What are the various antiplatelet drugs classification? One is TXA2 synthesis inhibitor, low dose of aspirin, phosphodiesterase inhibitor, dipyridamole, silestrazole, thienopyridine derivatives, that is ADP antagonist, diclopidine and clopidogrel. GP2B 3A receptor antagonist, that is abscizumab, aptifebatide and tirofiban. Others prostaglandin, that is PGI2, daltroban, dasoxiban, clofiprid. Daltroban is a TXA2 receptor inhibitor drug. Daxoxiban, that is thromboxane synthesis inhibitor. So and also various drugs, Dextran 70, nitric oxide is also used in the treatment for antiplatelets. Aspirin. What is the mechanism here is going on? You see this figure, acetylates, it inhibits enzyme called COX1 and TX synthetase. It inactivating them irreversibly because platelets are exposed to aspirin in portal circulation before it is deacetylated during first pass in liver, and platelets cannot synthesize fresh enzyme as they do not have nuclei, because TXA2 is suppressed at very low doses until fresh platelets are formed. Thus, aspirin induces prolongation of bleeding, lasts for 5 to 7 days. Effect of daily dose accumulates, and it has been shown that dose as low as 40 milligram per day. It can be implemented to antiplatelet action minimal or maximal at 160 milligram aspirin per day. So we know what is the mechanism in non-steroidal anti-inflammatory drug. Example is aspirin. It can block the prostaglandin action via COX-1. You want to inhibit the COX-1 enzyme. So aspirin also inhibits the COX-1 enzyme and PGA2 synthesis in vessel wall. But intimal cells can synthesize fresh enzyme. Activity returns rapidly. It is possibly that low doses 75 to 150 mg per day or 300 mg bi-weekly. It suppresses TXA2 formation selectively, whereas higher doses 900 mg per day kg per day may decrease the both thromboxanes as well as prostaglandin production. It also inhibits the release of ADP from platelets and thus sticking to one another. So, aspirin having a that is a non-steroidal anti-inflammatory reaction as well as an antiplatelet reaction. So we know one small example I want to tell to all guys. In case you want to have a fever, you want to administer aspirin. It is a nice drug. But in case of dengue fever, you cannot administer aspirin. Why? A dengue fever patient having a platelet count was less. Whenever you have a fever, you can take an aspirin. It is a nice choice. But in case of dengue fever, you are taking aspirin. Aspirin having an antiplatelet action. So already dengue fever patient having a platelet count was less. So you are giving means the patient will go for a die. That's why in case of dengue fever, you cannot administer aspirin. Very important example. Dipridamole. Dipridamole, it is a coronary vasodilator and relatively weak antiplatelet drug. The mechanism of action, there is potentiate effect of endogenous prostacyclin in high concentration inhibits phosphodiesterase. That is, so increases the CAMP. Dose was 100 mg BD per TDS. Dipridamole alone has a little effect, but in combination with warfarin or aspirin is effective, very effective. As a vasodilator used during myocardial perfusion imaging, that is thallium scanning, I think, to dilate and evaluate arteries of patients with the CAD. So diprodamol is a very important drug of choice for antiplatelet drugs. Okay. Next is ticlopidine and clopidogrel. Ticlopidine is well absorbed orally. It is an active metabolite in liver, so long acting half-life. After single dose is 8 hours, on repeat administration is 8 days. Ticlopidine can cause mild to severe neutropenia. Patients who are treated with ticlopidine must have a complete blood count with white cell differential every 2 weeks from second week to third month of treatment. After 3 months, CBC is recorded only when symptoms of infection. So ADP antagonist inhibit binding of ADP to its receptor irreversibly. It also inhibits fibrinogen-induced platelet aggregation without modifying GP2B and 3A. So having a synergistic action with the aspirin. Both our drugs have long duration of antiplatelet effect. Clopidogrel, a conjugate of ticlopidine, it is a better tolerated drug also. Okay. Ticlopidine versus clopidogrel. Adverse what you saw means diarrhea, vomiting, abdominal pain, headache, tinnitus, skin rash, bleeding, neutropenia, and thrombocytopenia for ticlopidine. Dose was 250 mg BD. In case of clopidogrel, bleeding most important, less bone marrow toxicity, diarrhea, epigastric pain, rashes, and dose was 75 mg OD. Okay. What are the various uses of antiplatelet drugs? That is PPCCCV. That is how I want to tell means. It is a prosthetic heart valves and AV shunts, peripheral vascular disease, coronary artery disease, myocardial infarction, unstable angina, and primary and secondary prevention of MI, coronary angioplasty, stents, bypass implants, cerebrovascular transient ischemic attacks, and venous thromboembolism. Prosthetic heart valves and AV shunt, that is means what means used with warfarin, reduced formation of microthrombi and leads to a artificial heart valves and incidence of embolism. Diprodamol does not increase the risk of bleeding, but incidence of thromboembolism is reduced. when it is combined with the oral anticoagulant. Antiplatelet drug also increases the patency of chronic eviction implanted for hemodialysis and of vascular grafts. Peripheral vascular disease. It may produce some improvement in intermittent claudication and reduce the incidence of thromboembolism. Coronary artery diseases. It is a coronary artery disease, myocardial infarction. I think low dose aspirin started immediately, and also you can give for administered AMI, acute myocardial diagnosis has been better been made and continued throughout the courses and after recovery. Unstable angina is there means aspirin reduces the risk of MI and sudden death in patients with unstable angina. Primary and sudden MI, you want to administer what? Aspirin as well as anticoagulant therapy, and also you go for a vasodilator also. Okay, these are the drugs and these are the uses of antiplatelet drugs. And there are two classes of antithrombotic drugs. One is anticoagulants and antiplatelets. Already I discussed in two topics before. There is anticoagulants and antiplatelet. What is the mechanism behind that? In previous itself, I can explain that anticoagulants slow down clotting, thereby reducing fibrin formation and preventing clots from forming and growing. But antiplatelet agents prevent platelets from clumping and also prevent clots from forming and growing. Difference you can understand it. Anticoagulant is different, antiplatelet is different. Okay. Thank you for your patience. Thanks once again.